Very good afternoon, and thanks Devin, and thanks to AOS for giving me this opportunity to be here. Uh, it's only a very practical thing which I'm going to show you. And as Dr. Devin has told you very clearly about how to read the disc, just to re-emphasize, the disc size and shape is important, and of course all the other findings, the neuroretinal rim, the notching, the pallor, each one I have a lot of slides, I'll just show you. And the vascular alterations, especially the disc hemorrhage, which is very commonly seen with the normal tension glaucoma, and where you see the progression, and you have to how to look at the absorbing hemorrhage and the RNFL loss associated with that. Then you have the retinal nerve fiber layer defects, local slits and wedge or diffuse defects. You can see the pictures, a lot of pictures are there. And the peripapillary area, especially the peripapillary atrophic changes. So just look at this slide. The media is very clear. That is the first thing which you have to be very careful. If the media is not clear, or if you have very small people, make sure that you dilate. The other way is when you have done the visual fields, especially with the octopus visual fields, then you can see the polar graph where you can easily see the defects, and then you can go back and see the optic disc, and then you can easily identify the RNFL loss. So this is a small disc, relatively a small disc, but as Dr. Devan was mentioning, if you have a very small cup also in a small disc, you must look for the notching. You can see the notch here very clearly. You can see the notch, and then you can see the RNFL loss, beautiful RNFL loss. And the same way, there is a little bit of asymmetry in the optic nerve head. The peripapillary area seems to be all right. Only the RNFL defects is very prominently seen. But if you are not comfortable, or if you just miss it, always see the red-free photographs. Nowadays all the fundus cameras comes with the nice photographic technologies. You just have to take one picture and it automatically just gets converted to black and white. You can see beautiful RNFL loss. This is a small disc, and you can see an obvious asymmetry between these two eyes. But what is that important is the cup and the peripapillary area is important, and also you can see the large RNFL loss. So you can see that RNFL loss in both the eyes. And the next picture is almost the same. You can see there is a asymmetry of the disc size. You can see the large cup, but the RNFL loss is very small. So large disc with the large cup, and many times the problem is when you have a 0.6 or 0.7 cup, we tend to tell the patient you have a 60% damage or 70% damage. So just make sure that you never tell the patients like that, unless otherwise you do the visual fields and do the staging, mild, moderate or severe. Till that time, don't tell the patient you have so much of damage. Sometimes you may be seeing about 0.9, but the damage may be very less. So be careful in whatever you are talking to the patients. You can see that RNFL loss on the right side, and you can see this is a little large disc, and the cupping is also large. And you can see in the left eye, you can see the hemorrhage here, and then just correlate that. You can see a beautiful hemorrhage and then associated RNFL loss. And you can see that this is a small boy about 5 years, not 5 years, 7 years old boy. This is essentially a normal. You can see a disc is a little larger, but almost same disc size. But you see this cup is definitely larger than this cup. And you see this vessel. I just want you to focus on this particular vessel. You can see the cupping is here. And just focus this. You can see that beautifully here. This is where the cup is, and I'll just show you the next picture. Now you see where the cup is. The cup has become much more. This is a stage Weber syndrome, but I just missed it. In the sense, before taking the photograph, I thought the progression was not there because the IOP was only 18. But in a young boy like 18, you have to be still suspecting whether the disease is progressing or not, because they tend to have an expansion of the sclera because the sclera is not very hard enough. So you have to be very careful. You can see the very minimal enlargement of the cup, so you have to start the bond medication. This is very small change, but it is very important. And the disc is definitely, there is a little bit of asymmetry, and see the placement of the cup, and there is an inferior notch, that's a focal notch, and along with that you can see the RNFL loss beautifully picked up by this. You can see quite a huge RNFL loss. And anybody wants to guess? This is, you can see the almost the normal disc size, and you see the neuroretinal rim is healthy enough and the cup is okay. And see this, the picture shows there is a pallor. The possibility is, one is overexposure of the light, so that it may appear to be pallor, but patient had a true pallor also. And sometimes you may tend to miss this RNFL loss. That's why what is important is you go one by one so that you will not miss. If you see the pallor, it does not necessarily mean it is only neurological defect. It may be glaucoma, or it can be a combination of neuro with glaucoma. So don't miss that. You can see that this is an angle closure glaucoma. You can have very high IOPs with the pallor of the neuroretinal rim, and at the same time the cup can be very shallow. With the RNFL loss, you can see the RNFL loss, you can pick up this here. So don't get the misconception saying that pallor means it is only neurological. It is not so. That's the only reason I wanted to show that particular picture. And you can see the disc hemorrhages. Here you can see beautiful disc hemorrhage. You can see the very large cup, and you can see black and white pictures. You can see very beautiful with RNFL loss along with that. And same, and you can see the RNFL loss here. This is the black and white picture which really picks up. Once you see one disc hemorrhage, especially in the normal tension glaucoma, you have to keep on looking for any new hemorrhages are occurring. Once the hemorrhage is absorbing, you can see the enlargement of the RNFL loss. So you have to be carefully watching that. You can see this is absorbed now, but you can see slowly there is a starting up of the RNFL loss there. And here there is no disc hemorrhage. This time when the patient came again, he had a disc hemorrhage in the left eye. And again you can see this is the fresh hemorrhage occurring. Already there is a large defect of wedge defect. You can see here also there is a small defect. And this is the same with the black and white picture. You can see a large hemorrhage here. This is not the fresh like the previous photograph. This is a really fresh one. You can see how much is the color change here, and then you see this. This is probably not the fresh one, but you can see the RNFL loss on both the sides. This is the black and white picture, and you can see this is absorbing. This is absorbing hemorrhage and the RNFL loss.
Just go back.
Which one you want?
So, this is something which you would like to focus on, even though you're looking at this.
This area. This area. Want to comment on that? Okay. Okay. So Dr. Devandan was telling about the bearing of circumlinear vessel. You can see beautifully here. So, but in the black and white picture, you can obviously easily make out that. But somehow I am very fond of black and white pictures where you will not miss the findings. Always the color photographs you might miss some findings, but the black and white gives you all details. So never miss to see even the cobalt blue filter when you are using your slit lamp. Please do use it when you are looking at the glaucomatous disc, so will not miss anything. And this is another large disc with a large cup, and the NFL loss, you can see there's a bigger area of RNFL loss. And this is a vertical disc with a vertical cup. Many times with a vertical disc with a vertical cup, you may not be seeing any defect. So what we mistake is it may be glaucomatous disc, so just don't miss it, but always keep looking at the RNFL area whether you really have a loss or not. Once you have a loss, then you can say, okay, there is a possibility of glaucomatous changes. Otherwise, okay, you can see this right eye is essentially normal. You can see the left eye. This patient had undergone both eyes trabeculectomy. In the left eye there is a bleak. So you can see the vessels are little tortuous, and there is a hypertonic maculopathy associated with it. You can see the cup is getting filled up, and you see this black and white. You see this now, the cup is become large. I have done the bleb revision. So after that you can see the cup has become again to the same size, original size. So you have to be very careful. When you see a small cup, it does not mean the patient is not having glaucoma. So you have to look for hypertonic maculopathy, especially those with trabeculectomy surgeries. And the field defect will be always persistent. Whether the cup has become small or large, the field defects will remain. So this is the RNFL loss. You can see a very small slit defects, different, you can see the slit defects here. You can see the defects here, wedge defects. And you have the superior defects, and you have the superior one, then you have the inferior ones, then you have the biarcuate defects and inferior large ones. You can see these beautiful pictures. And there's a RNFL loss here. I'm not able to see this and this both because both are tilted in a different angulation. Okay. Again, you can see the RNFL loss here with the inferior notching. There are a lot of slides with the inferior notch, and as the time is going up, this is the peripapillary area which you have to be focusing on. See the peripapillary atrophy of both alpha and beta zone, especially when you have a very large, large cup. Just focus on this peripapillary area also. You can see the peripapillary atrophy, but not necessarily it has to be pathognomonic in every given patient. Sometimes it may be just present from earlier also. So these are peripapillary changes. It may not be corresponding to the amount of damage. That's what you need to understand. It may be just present earlier and then it is probably progressing also. So this is why how I draw. To be truthful, there is no any set criteria, but whatever you see, like what Devan was mentioning, whatever you see, very important ones you draw. The vessels where there is a bearing of circumlinear vessel or RNFL loss, where the focal notching is there, and you specifically draw it so that you understand when the patient comes back to you. Otherwise, you might be missing. Just put one round and another round and then just put vessels. You may not be having enough of documentation in there. So specific areas, important. If you feel those areas, you just draw it what you see there. So just keep the eye and then keep drawing that eye and then finish, go to the other eye and then draw. Otherwise you will tend to miss a lot of findings. So thank you so much.